Welcome to Respiratory Care in Alternative Settings. This is based on Egan's Chapter 56. By the end of this chapter, you should be able to describe alternative care settings in which respiratory care is often performed, discuss more recent developments and trends in respiratory care at alternative sites, identify who regulates those alternative care settings, and list standards that apply to the delivery of respiratory care in alternative settings. You should also be able to describe how to help formulate an effective discharge plan for a patient. List factors to evaluate when assessing alternative care sites and support services in order to discharge patients. Discuss how to justify, provide, evaluate, and modify oxygen therapy in alternative settings, and explain how to select, assemble, monitor, and maintain O2 therapy equipment in alternative settings. You should also be able to identify the special challenges that exist in providing ventilatory support outside an acute care hospital, and describe how to instruct patients or caregivers and confirm in their ability to provide that care in the home or another alternative setting. You also, by the end of this lesson, should be able to identify which patients benefit the most from ventilatory support outside the acute care hospital. And last, you should be able to explain how to select, monitor, and maintain portable ventilatory support and continuous positive airway pressure equipment, including the applicable interfaces or appliances. You should also be able to describe the proper documentation regarding patient evaluation and progress in the alternative setting, including home, and state how to ensure the safety and infection control in alternative patient care settings. All right, so I want to ask a question. Who is this and what did he do for healthcare? How is he related to alternative care settings? Well, you should have been able to answer that this is former President Barack Obama. He is helped bring about the Patient Protection and Affordable Care Act of 2010, and we're going to talk about that in just a minute. There have been several developments in the area of respiratory care and alternative sites. Changes range from governmental initiatives affecting reimbursement to enhancements involving respiratory equipment. Over the past couple of decades, there's been an assortment of legislation and regulation enacted, like the Affordable Care Act, that have either reduced reimbursement for respiratory care in alternative settings or enhanced it. Also, with some exceptions that we're going to talk about, reimbursement for RT time spent setting up equipment and assessing and administering prescribed treatments for patients isn't always recognized. This presents some challenges to organizations and agencies attempting to provide quality care in alternative settings. The Patient Protection and Affordable Care Act, or Obamacare, of 2010 has expanded healthcare coverage to many uninsured Americans and prohibits the exclusion of pre-existing conditions and increases the scope of coverage for certain types of preventative care. This law also encourages the formation of accountable care organizations, or ACOs, These are groups of doctors, hospitals, and healthcare providers who voluntarily come together to deliver coordinated patient care. However, there are many provisions in this law that are still being modified and others that we're just starting to see implemented. So we really don't know the exact impact of this bill on respiratory care in general and in alternative settings. Even more recently, some states have and continue to review and pilot programs that reimburse for certain therapies and education done by respiratory care, like asthma care. Specifically, some states' Medicaid programs are planning to begin reimbursement for asthma education. Furthermore, the American Association of Respiratory Care, the AARC, through its Government Affairs Initiative, continues to promote legislation and sponsors efforts to expand the recognition and the role of registered respiratory therapists. A further development stemming from the aging U.S. population is a significant increase in the popularity of another form of alternative care site known as an assisted living facility. These facilities permit residents who are generally elderly or disabled to live in their own units either alone or with a companion. These arrangements permit the residents to live relatively independently, but with the convenience and safety of routine health services close by. A growing number of home care and other alternative sites have RTs providing care to patients at these locations. Other changes affecting RTs and alternative sites have resulted from research study outcomes. Starting in the late 1990s, there's been a small but growing body of research that indicate that patients in alternative settings have better outcomes when treated by RTs. It's hoped that this encourages public agencies and private agencies to recognize the value of RTs in alternative settings and to shape their policies accordingly. Let's talk a little about terms and goals. We'll start with post-acute care. As the elderly population increases and managed care becomes the dominant delivery mode, more healthcare services are being provided outside of an acute care hospital, in skilled nursing facilities, long-term acute care hospitals, and subacute care hospitals, and home care. Some of the most common respiratory care services provided in post-acute care facilities are continuous oxygen therapy, long-term mechanical ventilation, aerosol drug therapy, airway care like trach care, sleep apnea treatment and monitoring, and pulmonary rehabilitation. Long-term subacute care hospitals, or LTACs, provide highly focused care to patients with complex medical conditions, including patients who may have been on a ventilator, been ventilator dependent, or are difficult to wean. They may also have a trach. Advances in technology, research, and clinical specialization have permitted acutely ill patients to be treated outside of large-scale acute care hospitals, and over the past decade, LTACs have become much more prevalent. These facilities provide highly skilled care that's focused on patients with complex medical conditions and include patients who have been vent-dependent and are difficult to wean. Generally, LTACs employ a highly experienced clinical staff, including many RTs, to provide integrated interdisciplinary care using the latest equipment and protocols. During a 20 to 30-day typical length of stay at an LTAC, patients commonly experience significant improvement, including successful ventilator weaning and increased functionality. Subacute care. Subacute care, according to the National Association of Subacute and Post-Acute Care, is a comprehensive level of inpatient care for stable patients who have experienced an acute event resulting from an injury, illness, or exacerbation of a disease process. They have a determined course of treatment and require diagnostic or invasive procedures, but not those requiring acute care. Typically, the severity of the patient's condition requires active physician direction with frequent on-site visits, professional nursing care, significant ancillary staff services like RT, and an outcome-focused interdisciplinary approach employing a professional team. The goal of acute care is to apply intense resources to stabilize patients after a severe episodic illness, whereas subacute care aims to restore the whole patient back to the highest practical level of function, ideally self-care, and being able to go home. This holistic approach requires a goal-oriented interdisciplinary team with frequent assessment of progress and a time-limited plan of care. Although most patients receiving subacute care are elderly, all age groups can be found at these sites: pediatric, adolescent, and adults, requiring ventilatory support or extensive care depending on their diagnosis. Home care. Currently, most respiratory care in an alternative setting is provided in the patient's home. The primary goal of home care is to provide quality healthcare services to patients in their very own home, minimizing their dependence on institutional care. In regard to respiratory home care, several specific objectives are evident. Respiratory home care can contribute to the following: supporting and maintaining life, improving patients' physical, emotional, and social well-being, promoting patient and family self-sufficiency, ensuring cost-effective delivery of care, maximizing patient comfort near the end of life. Some of the most common clinical conditions that we see and treat at home are COPD, cystic fibrosis, chronic neuromuscular disorders, chronic restrictive disorders, and lung cancer. Standards for the delivery of respiratory care in subacute and home care settings come from AARC Clinical Practice Guidelines, federal and state laws, and private sector accreditation standards. Most reimbursement for care in alternative settings is through either federal Medicare or state Medicaid programs. As the largest purchaser of health services, the federal government, in connection with state and local governments, plays a major role in setting standards and regulating the industry. The federal agency responsible for the overall administration of Medicare and Medicaid is the Centers for Medicare and Medicaid Services, or CMS. This was created in 1997, and CMS oversees the framework for providing health coverage to elderly adults, disabled adults, and many disadvantaged young children in the United States. As part of this structure, CMS created the Medicare Provider Certification Program. This program ensures that institutional providers that serve Medicare beneficiaries, including hospitals, skilled nursing facilities, long-term acute care hospitals, home health agencies, and assisted living facilities, meet minimum health and safety standards. These conditions of participation emphasize quality indicators, outcome measures, and cost efficiency. Institutions undergo certification surveys to determine their compliance with these standards, and each state also has its own regulations in place for quality assurance. Because regulations for states are different, the state health department should be consulted for details on regulations in your state. Private sector accreditation. The primary organization responsible for standard setting and voluntary accreditation of care providers in alternative settings is the TJC. This is the Joint Commission. To assist hospitals and healthcare organizations with the accreditation process and overall performance improvement, the Joint Commission develops and publishes standards and national patient safety goals for long-term and subacute care, home care, and assisted living facilities. The standards and goals relate to the delivery of quality patient care and the process and structure needed to do so. Categories include patients' rights, ethics, assessment, and organizational leadership and management of information. The patient safety goals target for improvement in common problem areas for healthcare organizations such as proper patient identification, medication safety, and infection control. Approximately 90% of all hospitals and other healthcare organizations voluntarily subscribe to the Joint Commission accreditation, and as a result are surveyed at least every 3 years. Insufficient or unsatisfactory compliance is flagged and requires formal follow-up to ensure correction. In certain circumstances, such an unfavorable result may translate into a facility or organization failing to maintain the Joint Commission accreditation. Traditional acute care versus alternative care settings. For an RT, working in an alternative care setting, it's distinctly different from working in an acute care hospital. Some key differences involve resource availability, supervision and work schedules, documentation and assessment, and provider-patient interactions. Although some practitioners do not like alternative work settings, many find greater independence and greater rewards because of the patients, the team orientation, the creativity, and the higher level of patient and family interaction. It's very rewarding. Transport is another alternative care setting and an integral part of getting a patient from one place to another. Discharge planning. Effective discharge planning provides the foundation for quality care in alternative care settings. A properly designed and implemented discharge plan guides a multidisciplinary team in successfully transferring a respiratory care patient from a healthcare facility to an alternative care site. Effective implementation of a discharge plan ensures the safety and efficacy of a patient's continuing care. In addition, Medicare's readmission reduction program, which is part of the ACA, penalizes hospitals that have high short-term readmission rates for selected conditions like COPD and CHF. In general, the key elements of such protocols include proper patient screening and evaluation, early identification of patients at high risk for short-term readmission, intensive patient and family education, multidisciplinary discharge planning that addresses all major potential barriers to discharge, patient follow-up. To guide practitioners in providing quality care, the AARC has published clinical practice guidelines for discharge planning for respiratory care patients. Although physicians normally initiate an order to discharge a patient to an alternative site, many other healthcare professionals are involved in the discharge process. There may be utilization review, discharge planning, physician, respiratory care, nursing, dietary, physical and occupational therapy, psychiatry, and a DME supplier or home care company. Site support and evaluation. The primary factors determining the appropriate site for discharge are the goals and needs of the patient. These goals and needs should be met in an optimal and cost-effective manner using what resources are available at the proposed site. The staff of the selected facility must have all the competencies required to meet the patient's needs. They must be able to provide other needed healthcare services like physical therapy if needed and provide round-the-clock coverage. The performance of a particular skill is imperative for the discharge team to ensure that an adequate number of professional and non-professional caregivers are part of the care plan to provide appropriate patient care coverage. This is particularly true when more complicated modes such as mechanical ventilation or multiple therapies are required by a patient. Generally, substantial caregiver strain is associated with the care of such patients in alternative settings. A reliable, durable medical equipment supplier also may need to be involved. Home oxygen therapy and oxygen therapy in alternative sites. O2 therapy is the most common mode of respiratory care in alternative respiratory care settings. The high use of oxygen is based on the fact that oxygen therapy improves both survival and quality of life in selected patient groups, such as advanced COPD. In particular, studies have shown improved nocturnal oxygen saturations, reduced pulmonary artery pressure, and lower pulmonary vascular resistance has happened with appropriate outpatient oxygen therapy. To guide practitioners in providing quality care, there is a practice guideline on oxygen therapy in the home or extended care facility from the AARC. It includes how an oxygen prescription should read. The oxygen prescription should be based on documented hypoxemia as determined by either a blood gas or a pulse oximetry. Prescriptions for oxygen therapy can't be based simply on patient diagnosis or signs and symptoms. We need hard evidence. In addition, as-needed oxygen isn't acceptable in an alternative care setting. When the need for O2 therapy is established by blood gas or pulse oximetry, a physician needs to write an oxygen prescription. The prescription must include a flow rate in liters per minute or concentration or both, a frequency of use in hours per day and minutes per hour, if applicable, duration of the need, diagnosis such as severe primary lung disease, secondary conditions related to the lung disease and hypoxemia, and laboratory evidence, the arterial blood gas or the pulse oximetry under the appropriate testing conditions such as room air and walking. Home care companies can't provide this testing. It needs to be done by the respiratory therapist. For home use, the ordering physician must authorize O2 therapy using the CMS certification of medical necessity form for O2. So how do these people get oxygen in an alternative setting? Let's talk a little bit about that. Most alternative care sites don't have bulk O2 storage or delivery systems, piped in O2. In these settings, oxygen is normally supplied from one of the following three sources: compressed O2 cylinders, big old H tanks, liquid O2 systems, or oxygen concentrators. The oxygen concentrators are some of the most common method. Here's a picture of many different oxygen concentrators, both small portable ones and bedside. This is a liquid oxygen system. You can see in the top picture a cow, and in the bottom a small portable unit being refilled by a respiratory therapist from the cow. Liquid oxygen is use it or lose it. So the cows need to be refilled every week. Oxygen delivery methods. Oxygen delivery methods include nasal cannula, which is the most common oxygen delivery system for long-term care, but also don't be surprised if you see transtracheal oxygen therapy used in selected patients. It's pictured here. It conserves the use of oxygen and has cosmetic advantages. It can be easily covered by a scarf. Another type of common oxygen system used is a demand flow oxygen system. A demand flow oxygen delivery device, also known as an O2 conserving device, uses a flow sensor and a valve to synchronize gas delivery with the beginning of an inspiration. All the oxygen delivered during the latter half of inspiration and throughout most of expiration is wasted. However, a synchronized pulse of oxygen delivered at the beginning of inspiration can produce oxygen saturation levels equal to those seen with continuous flow if using lower oxygen levels and if synchronized correctly. In theory, demand flow O2 systems provide the greatest savings in oxygen use for a given level of arterial blood gas saturation. Recent improvements in the demand flow systems have made them more reliable and much more user-friendly, addressing many of the major disadvantages of earlier versions. As a result, these improvements and the ability of these devices to increase the duration of flow by 2 to 3 times, they've now gained a wide acceptance. This is a demand flow oxygen delivery. With continuous, most of the oxygen is delivered during the first half of the inhalation with the remainder wasted. But B, with a coordinated pulse, most of the oxygen is delivered during the first 25% of inspiration and no waste occurs. Providing successful ventilatory support outside the acute care hospital requires careful patient selection and good discharge planning. Key factors include an interdisciplinary team, effective caregiver and family education, thorough assessment and preparation of environment, and careful selection of the needed equipment and supplies. Until recently, non-invasive positive pressure ventilation by tracheostomy and invasive positive pressure ventilation by tracheostomy was the default standard for long-term mechanical ventilation, especially for patients requiring 24-hour support. However, long-term tracheostomy is associated with some potential problems, including secretion retention, infection, aspiration, and ventilatory-associated pneumonia or VAP, as well as communication difficulties between the patient and the caregiver. Because many long-term care facilities treat a tracheostomy as an open wound, patient placement at certain sites is prohibited. Last, invasive ventilation by tracheostomy poses significant limits on a patient's quality of life. For these reasons, non-invasive support is becoming increasingly popular. Non-invasive mechanical ventilatory support involves any method designed to augment alveolar ventilation without an endotracheal tube. Non-invasive ventilation, or NIV, is usually the first choice. Any individual requiring a mechanical ventilator can be supported with NIV if the following happens. The patient needs to be mentally competent, cooperative, and not using heavy sedation or narcotics. Supplemental O2 needs to be minimal, usually an FiO2 of less than 40%. Sacs need to be able to be maintained at greater than 90% by aggressive airway clearance techniques. Facial muscle function is a must. The patient has to be able to swallow and cough and protect their airway. Unassisted or manually assisted peak expiratory flows during coughing need to exceed about 3 liters a second. No conditions are present that interfere with non-invasive interfaces such as facial trauma, an inadequate bite for the mouthpiece, or an oral or nasogastric tube or facial hair that can hamper an airtight seal. Patients who can benefit from NIV, non-invasive ventilation, generally fall into one of two categories. Patients in the first category have conditions in which cessation of ventilation could lead to imminent death. This category includes both acutely ill patients and patients requiring long-term 24-hour support. Patients in the secondary category have conditions in which NIV may offer clinical benefit, but cessation is not life-threatening. Generally, these patients require only intermittent or nighttime support. Patients in this category include patients with chronic neuromuscular disease, chest wall dysfunction, muscular dystrophy, or kyphoscoliosis. Ventilator support in alternative setting has to have planning. Including caregiver education. Successful home ventilatory support requires extensive planning, education, and follow-up by all members of a home care team. Basic steps in the discharge process for a ventilator-dependent patient include that the family is consulted and is willing to take on the responsibility of a ventilated family member. The physician writes an appropriate order. A discharge planner coordinates effort of all team members and makes a discharge plan. The physician and other healthcare team members discuss the plan with family and caregivers. Education and training are initiated and completed by family members, and the patient and the family feel prepared for discharge. This includes a home layout assessment, equipment and supplies gotten to the home, and that the discharge planner coordinates final preparations. The patient may be discharged with a trial period, possibly. Local power companies must be notified that there's life-saving equipment in the home, and appropriate backup power like a battery is needed. Ongoing follow-up care is provided by a visiting nurse, RT, and other home health professionals as needed. Selecting the right ventilator. The choice of a ventilator for a patient in an alternative care setting should be based on the patient's clinical need and the available support services. In some cases, a patient may dictate that more than one ventilator be provided. A second backup ventilator should be provided for patients who cannot maintain spontaneous ventilation for more than 4 consecutive hours. For patients living in an area where a replacement ventilator cannot be secured within about 2 hours, and for patients whose care plan requires mechanical ventilation during mobility, a second ventilator is appropriate. Ventilators used in alternative sites must be dependable and easy for the caregivers to operate. They need to be portable for patients who are mobile. Electrically powered ventilators often are the best choice, so a backup battery or multiple batteries is needed. Let's start talking about positive pressure ventilators. Here are a few of the most popular models: the Philips Respironic Trilogy and the CareFusion Laptop Ventilator, or LTV. Here you see a Respironics REMstar bi-level. Positive pressure ventilators, for most patients, especially those with COPD, prefer a pressure-limited over a volume-cycled ventilator. It's more comfortable. Those with neuromuscular disorders may prefer volume ventilation. However, the biggest challenge with non-invasive positive pressure ventilation is getting a good, comfortable, leak-free interface. Old school negative pressure ventilators, the iron lung, pictured here. And the chest carafes. The chest carafes, or turtle shell, you can see a picture in the first picture. It's a picture from the 1950s. It's been around for a long time. However, the last three pictures you can see are the newer chest carafes. The original negative pressure ventilator was the iron lung, and it was used for patients needing ventilator assistance after polio. For practical reasons, that cumbersome iron lung was essentially replaced by the chest carafes, wrap, or pneumosuit. The chest carafes, a rigid shell that's pictured here, and wrap-type system nylon fabric surrounding a semicircular tent-like support, are simply enclosures that allow the application of negative pressure to the chest. These devices require a separate electrically powered negative pressure generator. An example of a negative pressure generator used to power carafes or wrap type systems is the Respironics NEV100. So the iron lung was replaced with the chest carafe, and negative pressure ventilators are not often used for ventilatory support in post-acute care settings. Generally, we see them in home care. Evaluation and follow-up. Patient parameters to be monitored during positive pressure ventilation are essential. The same parameters that are assessed in the acute care setting are what you will assess in an alternative setting. However, the emphasis is on simplicity. The caregiver should assess the patient's vital signs, lung sounds, sputum production on a daily basis, as well as arterial blood gases by an RT, should be monthly or only when changes in the care plan appear to be needed. Likewise, compliance and resistance measures are performed only when other evidence dictates that that's needed. Routine follow-up visits by an RT help to ensure the success of patient management in the home and that proper equipment is being maintained and functioning. Other modes of post-acute respiratory care that you may see: bland aerosol therapy. The delivery of bland aerosols has been common in alternative sites for many years. Depending on the patient's condition and therapeutic objectives, bland aerosol therapy may either be continuous, like for a trach, or intermittent. Though bland aerosol alone may have little effect on the properties of mucus or its clearance, it may be useful as an adjunct to other airway clearance procedures. The potential problem is infection from contaminated equipment. To reduce this incidence of infection, equipment and patient delivery systems have to be cleaned and changed regularly. Here's a picture of a disposable airway generator with a wrap heater that is not disposable. Aerosol drug administration. Bronchodilators and anti-inflammatory agents are given via metered dose inhalers, dry powdered inhalers, or small volume nebulizer. Reimbursable expenses related to aerosol drug therapy in the home are limited. However, this type of home unit is in general inexpensive and easy to use. It simply plugs into an electrical outlet with one on-off button. You can see where a nebulizer hooks onto a single port for compressed air. Airway care and clearance techniques. Patients in alternative care settings with a tracheostomy might need daily stomach care, suctioning, and possibly a trach change. In most alternative care settings, tracheal bronchial clearance is often accomplished by suctioning with a portable, electrically powered suction pump and a collection bottle and connection tubing. Proper suctioning procedures should also be taught to caregivers and, if the patient is able, to the patient. Education and training on proper suctioning methods may begin before the patient is discharged from an acute care setting, with reinforcement and follow-up as needed. Patients can be taught to independently apply coughing, forced exhalation, active cycle breathing, and autogenic drainage methods. Caregivers can be trained to apply chest physiotherapy and mechanical devices like the vest when retained secretions are a problem. Nasal CPAP. Nasal CPAP is an accepted form of therapy to treat sleep apnea. For Medicare reimbursement, the diagnosis must be confirmed by the polysomnogram or sleep study. The institution providing subacute or long-term care, the assessment and documentation process involves patient screening, treatment planning, ongoing patient assessment, and a discharge summary. In-home care. Factors to consider when determining the frequency of home visits for the RT should include a patient's condition and therapeutic needs, the level of family or caregiver support, complexity of the home care equipment, someone on a nasal cannula versus someone on a ventilator, overall home environment, and the ability of the patient to provide self-care. What does an RT do during a home care visit? They assess the patient. They see if the patient is compliant and their family with the treatment plan. They assess the equipment. Is it being cleaned properly? Does anything need to be added or taken away? They identify any number of patient problems. And their statement is related to patient goals and treatment plan. Is the patient meeting ongoing goals? Do the goals need to be adapted? Does the treatment plan need to be adapted? With many patients receiving respiratory care outside of the hospital, the danger of infection caused by direct contact with caregivers and visitors or indirect contact with contaminated equipment has grown. To help minimize home-related infection, guidelines for disinfecting home respiratory care equipment have been established. Accepted infection control techniques are based on clinical evidence, such as the evidence outlined in several AARC clinical practice guidelines that pertain to respiratory care provided in alternative settings. In regard to infection control, all guidelines and procedures mandate proper hand hygiene techniques by all caregivers, proper hand washing, and use of antiseptic hand lotion. In addition, visits to the patient by friends or relatives with respiratory infections are discouraged. They need to come when they're well, not when they're sick. About medical equipment suppliers, the guidelines suggest that all permanent equipment, like ventilator circuits, oxygen delivery equipment, and aerosol systems, be sterilized or receive high-level disinfection before being supplied to another patient. Disposable or single-use patient equipment must be used by one patient only. It's recommended that all equipment be completely disassembled and washed first in water, followed by a soak in warm soapy water for several minutes, with the equipment scrubbed as needed to remove any remaining organic material, such as secretions. Following this step, the equipment must be thoroughly rinsed to remove any residue of soap and drained of excess water. Air drying on a clean surface or rack is recommended, like a paper towel. Additionally, broad bactericidal activity exhibited by many manufactured disinfection solutions make them the first choice. Other disinfection solutions to be considered include a 1 to 50 dilution of 5.25% to 6.15% sodium hypochlorite household bleach with water for a minimum of 3 minutes. Distilled water should be used for humidification or nebulization. Palliative care. Palliative care is the last thing we'll talk about in this lecture. Although the primary goal of home care involves minimizing a patient's dependence on institutional care, an additional goal is to maximize their comfort and well-being, especially that of a terminally ill patient or one near the end of life. The definition of palliative care is it involves the control of pain and other symptoms such as dyspnea of the terminally ill or chronically ill patients and maximizing psychological, social, and spiritual well-being of family members and patients. Many terminally ill patients have respiratory dysfunction directly or indirectly resulting from their illness. Some of these patients choose to experience the remainder of their life at home. Hospice is usually introduced in the last 6 months of life. It can help support the efforts of such patients by providing clinician coverage and equipment to these patients at home. This is the end of our lecture. Thank you and have a great day.